So I'm going to hand over to Nicola Fleming first, who's going to talk us through, hopefully you can all see the presentation, and we'll just talk you through that as we go.
So a little bit about our team to start us off. We are the Community Hospital Discharge team for West Dunbartonshire HSCT, and what the team aims to do is identify people early on their admission to hospital who may require assessment or support to get them home safely and in a community manner from hospital. We provide an integrated approach to care, so we're looking to optimise independence for individuals and maximise their opportunities to get home and further improve their recovery at home. And we identify the requirement for ongoing support and ensure that people are transferred in a timely way to other appropriate services who would be looking at the longer term assistance that people might need according to what their primary care needs are. The team is made up of three components. The clinical rehab component is made up of a health team lead, 2 nurses, 3 physios, 3 OTs and 2 rehab assistants. The community OT part is made up of 1 senior OT and 2 OTAs. And the social work part is made up of a senior social worker, 8 social workers, 3 social work assistants, a hospital discharge coordinator and a financial assessor. We're closely aligned with other teams such as the mental health officers and the carers centre, and these people will attend relevant meetings within the hospital discharge team regularly, whatever's appropriate for them to do, so that we have close links with them.
So as you see, it's a very healthy team in terms of numbers, and it's different to how other partnerships might work in it. The team is what, as you'll see, a community hospital discharge team. So we're not just about being based in a hospital site and working within the hospital to the point of discharge. We actively work with people whilst they're in hospital and then support them at home for 4 to 6 weeks post-discharge. So you'll see the picture here. Apologies, really I would ideally like that to be in a clock face, because I think as anybody who's working in hospital discharge, I feel as that you always feel like you're working against the clock. So around 4 years ago, we made a massive overhaul to how our team was working. At that point, people were being referred to us at the point they were medically fit for discharge, and it very much felt as if not the person but their situation was therefore viewed as problematic, and that wasn't working for anybody, particularly the individual in that hospital. So really we wanted to receive referrals much sooner, so that when they were receiving their medical care, we were working with them, with their families, with the ward staff, to have appropriate conversations, to have good conversations, and to have an influence and lead that assessment in order that by the time the person became medically fit for discharge, that everybody was aware and in agreement of what that discharge plan would be. So we benchmarked with other areas. In particular, we looked to our neighbours in Renfrewshire and Inverclyde to see how they were working. And we decided at that point that we're going to stream the remits within the team, which is a bit of what Nicola has described there. So there was the balance between the number of handoffs that individuals might experience between workers if we were to stream workload, but it was also that bit about, at the time when we first looked at the team, there was workers were dealing with a number of competing priorities. So if it was the one person dealing with the individual throughout the whole process up to 6 weeks post-discharge, then that worker was getting pulled in all kinds of directions and therefore wasn't especially being effective in any of the remits that they were trying to undertake. So we streamed the roles so that we had hospital discharge liaison workers, and that's effectively the bit we're speaking about today, where it was that early in-reach and the bit about influencing the conversations in the ward. We supported discharge assessors, that's individuals who then, so the early assessors would be identifying the needs in the ward and would be identifying the most appropriate worker, their colleagues within the team who would then pick up the work. So supported discharge assessors are those who undertake the more complex discharges, so they're undertaking the single shared assessment for people who may be considered for a 24-hour care setting, or for people who would be going home with a significantly complex package of care. Our home discharge assessors I'm not sure how other areas work, but in West Dunbartonshire we have no delays attributed to the delivery of care at home. Our residents are discharged home on the request and effectively the prescription of the ward. So the ward requests the care package that they would like for that individual. We deliver that at the point of discharge, and then our home discharge assessors are going in within a week to review that under the umbrella of reablement and to try and reduce that and to promote the person's independence. We have a dedicated care at home hospital discharge team, and the staff within that team are all trained within reablement and the principles of that, and looking to support the individual's abilities and not just look for the deficit within that assessment. We have a dedicated care home placement review officer, so that's somebody who goes in for the 4-week review if somebody's discharged to a care home setting. So they pick that up at the point the person's admitted to care and engage with that individual and their family over that 4-week period, and then they do the 4-week review. That was brought in not immediately when we did the change of the team, but it was something that we recognised when we're looking at quality standards within care homes, that if somebody was placing a resident within care home A in January and wasn't placing somebody again in that care home until the next March, then they weren't able to pick up on if there was any nuances in the standards of care delivered within that care home. So by having a dedicated review officer for the care home placements who reviews everybody's placements, they were getting to have a feel of the care home settings, of the staff, of the management that could report back to us as a management team and to our quality assurance section if there was any changes in the standards of delivery of care. We also have our clinical rehab team who provide the reablement and the professional assessments, physio, OT, nursing, to support people to be discharged home, and Nicola will go into that in a wee bit more detail later. So as I say, we did balance the number of handoffs that individuals might experience with the dedicated time that workers could provide if they had a streamlined work plan, and over the number of years that this has been in operation, we found it to be a benefit to the individuals and the workers for it to work in this way. So this is another version of a clock face, but you'll see that this was what we first had ambition to achieve, and this is where we feel that we have worked, although we'll come on to, we're not making out as if we've got everything perfect here, but you'll see now that the referral to the HSEP is happening much sooner. That has required very active in-reach from us. In terms of that can be a bit frustrating at times, because if ward staff change or they're on different shifts, they might forget about making a referral to us. Also, in fairness to ward staff, West Dunbartonshire HSCP is one of 6 HSCPs within NHS Greater Glasgow and Clyde, so for ward staff to understand the nuances of referral pathways for different HSCPs is a challenge for them and for us, and that's something which we're now working to mitigate against, and Claire will go into that in a bit more detail. But really the whole ethos around this was the importance of early engagement and to be part of the conversations on the ward, to lead those conversations with the individuals and their families, and to have a significant degree of influence on that discharge planning process. So I won't go into the detail of each and every role, but in the next number of slides it describes that. I'm sure that you'll be able to access that, but we'll focus on the hospital discharge liaison workers, and this is the 2 workers who do that. But really the vision was for them to be present on wards, to be promoting awareness of the range of resources that are available in the community, and speaking with community nurses. We've been up and done some workshops or sessions in a number of acute settings, and I think ward staff are always amazed at the wealth of resource that's available in the community, and quite often can be surprised by that. So it's about reiterating that point, trying to limit risk aversion and promote people's ability to risk take, because as we all know, we all risk take on a daily basis, and because somebody goes into hospital, I always say this, nobody anticipates that the trajectory of their life is about to change on the basis of a hospital admission, and we should be trying to work to get that person home as much as we can. So the next number of slides detail the other roles. I won't go into them in detail, but you'll be able to see them from the slides if you download them later as to how we streamed that workload. This is the short or immediate to short-term impacts of having taken this approach. So you'll see in April 14 we peaked in terms of our bed days lost, and it came down very significantly until, well, it has continued to come down, but you'll see the very significant downward trend up until September 2016, and the impact that having very dedicated roles had. Nicola mentioned our close working with our mental health colleagues and our carer centre. We have somebody from the carer centre who's hosted within the team, and the local carer centre base a worker who's dedicated to hospital discharge. They base a worker with us 3 days a week, so that worker is picking up on the impact upon carers during that hospital admission and discharge. And also through our what was integrated care fund at the time, we pay for 1.5 MHOs as part of the overall cohort within the HSCP. That's a reciprocal agreement, so obviously the MHO cohort benefit from having those staff around, but we know that we are prioritised for those two particular workers' workload. It's weighted towards older people and in particular hospital discharge. So that was where we got to. That's the model we've been working to date. And then Jo and Claire are going to describe to you where we are at just now and what our future ambition is.
So, as you can see from that previous graph, the changes did result in a significant impact in terms of improving performance, but that's not always easy to maintain. And if you look at this bar graph, this is covering the period from the 1st of October 18 to around about this week. And you'll see we've had, difficult to find the word for this, a blip, a challenge, a deterioration in performance around the period of May to July this year. Now, nothing's changed in terms of the size of our hospital discharge team in that period, but has changed materially as some of the factors in the system around us. So one issue has been that we have had to launch a large-scale investigation in a local care home in the area, and as a result of that, we've jointly agreed to put a moratorium on admissions to that care home. That took a significant number of beds out of our system in quite a sudden period, really. So not only that would have reduced our capacity by 10 beds at any point, but seeing that flow through the system over a period of months, that starts to mount up in terms of admissions to care homes that we failed to make. The second factor was, because of that large-scale investigation, our hospital discharge team workers, who are normally solely focused on support and discharge from hospital, got diverted into looking at the quality of care in this care home. We didn't have a separate team that we could pull on in order to do that work. So the team, in a way, got distracted over that period. Third factor that I'm sure you're all feeling is winter started back in about November last year and hasn't really ended in terms of the demand we're seeing. So although we kind of try and increase capacity over the winter period, that kind of sustained demand has remained there ever since, both in acute and in our community services. And the fourth issue, and this sounds like a list of excuses, and I don't mean it to come across like that, we've been trying to open a number of additional care home beds that are within our own jurisdiction, that they're local authority beds, and the beds are available and all kitted up, but we've tried 3 times to recruit an appropriate caliber of staff to staff those beds, and we've not been able to find those staff. So we're out now for the 4th time trying to get the final number of staff we need to open those beds. So while the process has seen some improvement, it's not plain sailing, and we are definitely still subject to what can be seen as small changes in the system at any time. I'm going to hand over to Claire, who's going to talk a wee bit about how we're responding to that.
Hi, so now we have an opportunity which we can now look at inpatient activity. We have the opportunity now with a dashboard which gives us the opportunity to look at, we've got, as you can see, there's 6 tabs in the top. We have got current wards, patient in hospital for 10 plus days, short admission, bed days, admissions the last 7 days, and discharge the last 7 days. That gives us an overshot of all the patients that are within West Dunbarton that are sitting within Greater Glasgow. This gives us an opportunity now within West Dunbarton to be extremely proactive we can now reach into wards, and we do not have to rely on the wards coming to us. This gives us an exciting opportunity within hospital discharge, because it allows us to be able to reach at the earliest opportunity now. What we're looking at is that we are now able to look at snapshots and go into specific hospitals, specific wards, specific areas. This is then allowing us to see where the trends are in hospital discharge. For our remit, initially, what we're going to be looking at is the 10+ days, because these are the ones that we think that are the ones that are possibly the ones that we can make a significant difference with. We're looking at the bed days, we're looking at how we can look at giving a more person-centred care, and also to support our acute colleagues, because as discussed previously, we know that they're dealing with multiple HSAPs that are all dealing with different referral criteria and different organisations. So West Dunbarton is then getting an opportunity to go in and actually reach. When you're looking at the current specialities, that can give us a chance to look at overall for geriatric medicine, to go in and look and see and target the specific wards to see exactly what are the problems and to troubleshoot. This also gives us an opportunity to build up excellent working relationships, and also give us an opportunity to link personally with the patient and their families. So as you see, the dashboard records all of West Dun's residents, and that allows us again for being proactive. Our initial concern was for consent, but what we're discussing with the wards is when the ward staff are dealing with the patients and working with the patients, they can advise them that information will be shared with the HSCP. So, our plan, what the plan is going to be is to look at our dashboard, target initially, as I say, the 10+ days, and identify the themes. We will initially base ourselves in acute, and we will spend time in the wards. This will mean that we'll meet with DHP staff and relevant consultants, and all daily working with the patients. All staff will be interchangeable in relation to hospital sites, but we have to be sensible. We have to play to our strengths if relationships are established, because obviously we want to be as effective as we can be. Once our initial screenings are completed and we have decision making, then these will be passed, if appropriate, to relevant streams in the team, and they will run with them. This is obviously to try and minimise duplication. We also want to develop closer links with our housing colleagues, and also care at home staff and housing OTs. Because as you're all aware, one of the biggest problems is when someone goes into a hospital, is the first thing we get told is the house is not suitable. So we need to try and troubleshoot that as early as possible. But in doing that, also try and manage unrealistic expectations. Because what we don't want is the scenarios that we sometimes have, and no doubt we all have, is that people are told something that we cannot actually do. So we want to try and give someone in hospital the best care possible.
Okay, so thank you. Thanks to the team here. That's our formal presentation ended, but really keen to hear from you on your thoughts on any of that, or any questions or suggestions. It would be helpful perhaps if you could introduce yourself and tell us where you're from when you're contributing.
Thanks very much, folks. Yes, as we say, as she says, if anyone's got any questions, there's not many people online, so if you want to just unmute your mic and speak up and introduce yourself with any questions, just go ahead.
Hi, I'm Gail Robertson. Can you hear me?
Yes, Gail, we can.
I can hear you very clearly, Isla, but I'm sorry I couldn't hear the presenters very well at all. But your volume's fine, so I don't know if you're in, I don't mean using a different PC or whatever, but I'm Gail Robertson. I'm Patient Discharge Manager for the Deprivation Galloway Health and Social Care Partnership.
Hi Gail, we can hear you fine. It's a shame you weren't able to hear us. Sorry about that.
Yeah, it's very low. It's really
we did try and test the sound beforehand just to make sure it was working, so it was fine then.
Yeah, I mean, it's coming through fine here. I just don't know if it would be local systems or what. But I have taped the session, so if there's anything you missed.
Yes, I do. Recording them, yeah, recording them for other people to watch. That's good.
So did you have a question, Gail?
No, I was just introducing myself to the rest of the group who we were on.
Okay, thanks, Gail.
Oh.
So does anybody else have any questions for the team? Everybody's gone shy. I do have a quick question. It sounds from your presentation like you do have very good early engagement with patients and families, but I was just wondering, how do you manage, what do you do when things don't go to plan and patients aren't happy with the options they're being given? How do you manage those more difficult cases?
So I would imagine, like other people, we work with the Scottish Government guidance on choices, but obviously we try not to get to that stage because having formal meetings like that is not really in anybody's interest in terms of relationship. But we do, when it comes to somebody's assessed need, if it is about 24-hour care or if it is about somebody going home with, significant adaptations to their home, we would be having a discharge planning meeting. I'll give you an example. If somebody's going into a care home, we will look to offer interim placements if a care home of their preference is not available. We'll ask somebody to identify up to 3 care home settings where they would be willing to be discharged to. If none of them are available, and Joe has described a situation where, the one care home in a particular town was taken out of the equation for us, so that meant that anybody who would like to be discharged to that particular town, that wasn't an option at that time. So we would offer an interim placement in a suitable care home that offers that same level of care as close to that preference as we could. We will do that twice, and at that point, if both of those interim offers have been declined, then we will have a meeting with the family, and obviously it's under the guise of a choices meeting, but we then would seek to attend with a third option for that individual. And usually by that stage things do resolve because either there has been a bit more movement in care homes and a placement of choice has become available. But we do find quite often that people who will move to an interim care home, it's a care home they haven't considered just because they haven't been aware or they haven't known somebody who's been there in the past. So we find, I would say there's only about 40% of people who go to an interim who then decide that they do still want to move to their placement of choice when it becomes available. Most people move and settle and choose to remain. But it's just really about that, the open and honest conversation, being as honest as we can about managing the expectations. As Joe was saying, one of the care homes within our own gift that we're seeking to increase the bed capacity there. It's about managing those expectations for family because the local community are aware that there are no unoccupied units within the care home. They're aware that there are moves to have them staffed, and so some people are holding their breath for that to happen. So it is just about being honest with people and engaging at a human level, not trying to hide behind titles or hide behind an organisational banner.
Thanks very much. I think that's key. It's remembering you are dealing with people and it's not just about numbers, isn't it? Yeah. Okay, thanks very much. If there are no other questions, we'll just...
I have Isla, just a quick one, if that's okay.
Of course.
When you're talking about your interim placements, how far are these interim placements away from their first choice place?
So the geographical expanse of West Dunbartonshire will try to keep people within the West Dunbartonshire boundary. So I don't know the mileage of that, but if people are aware of the area, we're talking about Clydebank, which is just bordering on Glasgow, down to Loch Lomond sides at Balloch would be within our area. So sometimes we're asking people, we're asking people within that geographical bounds. On very rare occasions we might ask people to go into Argyll and Bute, but that would be as far as Helensburgh. So for some people who live in Dumbarton, that's as close as asking them to go to Clydebank. So I would imagine, I don't know the mileage, but really within I would imagine it's within a 10-mile radius, all in from placement of choice to where they're being asked to go on an interim basis.
Yeah, in Dumfries and Galloway, we have a 30-mile limit, and that's something that we've locally agreed as a partnership. So if there is an interim placement within 30 miles, the person has to move to that interim placement. We do have difficulties moving people. One of the other questions I had was, we find it much more difficult if the person is self-funding, and because we do get families and patients who are absolutely refusing to go to an interim placement that's maybe got a poor care inspectorate report, or they've heard stories about that particular home and they're absolutely not going to pay for it. Do you come across anything like that?
To be honest, yes and no. So the demographics of West Dunbartonshire, we're in one of the 4 most deprived areas in Scotland, so our number of self-funders is not as significant as some other areas. But we usually find that self-funders have identified somewhere with a bed. So we have care homes who have dedicated beds for self-funders, and then they have a commissioned cohort from the HSCP. So usually those individuals who are identifying a self-funded placement have already lined up with the care home or their manager that there is a bed available. So it's not as much of an issue for us.
I would add to that as well, 2 things. That what Kirsten's describing in terms of the levels of deprivation here, what that means is we have a lower than comparable partnership car ownership level. So talking to somebody about travelling 3 or 5 minutes to another care home, where some of us would think that's not a big ask, for some people that seems really difficult, and we're having more and more conversations like that. The other thing is, where you're mentioning care homes that maybe don't have an inspection report, we have experience of that also, and we're finding more and more that we need to liaise and have a stronger relationship with each of our independent care homes than maybe we did previously. Kirsten and I have been out to meet with one of them this morning, who's likely to have their grades downgraded in a report that's published shortly. And that's because we need to be reassured that they're making the improvements necessary so we can reassure families that this is a good placement. But we're finding that's more and more our business than it was previously, and it'd be interesting to know if other partnerships are finding that too.
Yeah.
Okay, thanks. Sally, you typed in there that you had a question. Do you want to come in now?
Can you hear me? Is that working? Can you hear me? Yeah, good. I was just intrigued about your personal care and how you arrange the personal care services from providers. Do you have your own in-house personal care, social care officers, or is it all external or a mixture?
90% of our care at home is delivered by our in-house team. So we are, we're probably quite unique in Scotland in that we have for in-house care at home delivery. So our immediate discharge delivery is delivered by our in-house team, and only 10% of that. But it would be our care at home colleagues who would engage with the private sector to deliver what they could not. So that's not a particular interaction that the staff within the hospital discharge team have.
So they do short-term and mainstream. If people need long-term personal care, your team does that. Yeah.
That's right.
Okay. Yeah. Thank you.
And to be honest, we benefit. There's pros and cons, of course, but we benefit from that in terms of having the levers to pull locally when we need to increase care at home in order to meet the demand that's coming out of hospital. It also means that we have we employ a lot of local people in care at home, so we can call on them when need be, and they're a very loyal workforce. So even if, say, we suffered badly from the beast from the east last year in this locality, but we managed to deliver quite a lot of services on the ground because staff are so local to where they work and are willing to work in the patch they're in rather than the patch they're normally in times of need. So it's quite a flexible workforce.
Yeah, that's interesting. And do you also find that, at time of discharge, you think somebody might need 4 times a day double up, but that when you actually get somebody home, it's not that? Or are you pretty consistent with your assessment at this time of discharge?
So, as I say, we frequently find that we can quickly reduce what the discharge package has been, but we do not assess for that discharge package at the point of discharge. That's the ward make that assessment and request. We deliver on that, but within a week are seeking to review and where we can reduce that care package.
Right, okay. Thank you. Oh, sorry, one more question. If somebody comes, I knew I had another one and it went out my head and now it's come back again. If somebody goes into hospital with services from you or with care provided from you, how long do you keep that on hold for?
Good question. I'm going to say off the top of my head 2 weeks that we were told that for.
2 weeks.
Yeah.
2 weeks. Okay. Thank you very much.
So, are there any final questions from anyone?
It doesn't have to be a question. Any comments or suggestions would be open to that as well.
Absolutely.
No, I think maybe that's it.
I think that is it. Silence was the reply. Yes, right. Well, thank you everyone for joining us today. Thank you to the presenters as well. As I say, the session's been recorded, so I'll check it over and see if we need to do anything with the sound on it. But hopefully, it's recorded to sound okay, and it'll get put onto our YouTube channel, and you can watch it again or share with colleagues that haven't been able to join us live. And just to say that the next class is on communication, and that's on the 1st of October, with the lovely Sally, who we've got online here at the moment, and colleagues from Inverclyde. So we'll hopefully you can join us then. But that's I'll just sign off the session now. Okay, thanks.
Thank you. Thanks everyone.
Well done. Thank you.